3, 2, 1, here we go. All right, we're kicking into chapter 20. 20. You realize that the end of A and P is only chapter 27?
So excited.
You've done 1 through 20, and you've only got 7 more to go. We've only got 2 more to go in this one, right? Maybe, yeah.
Why can't I figure this out? It's like my first thing.
So anyway, we're going to start talking about the heart. We talked about it the other day. I gave you the route of blood flow through the heart. And I'm just going to tell you that you got to know that cold. Okay? We're going to have another quiz on Tuesday. Maybe Thursday. What I'm trying to do is help you out a little bit here, because some of you could really stand to get rid of one of your quizzes or one more of your quizzes. If we take 7 quizzes, you get to throw out 2. So I think I'm going to try to shoot to get us up to 7 quizzes so you can throw out 2. I hate it when there's some of you that have to throw out a 21. In other words, you've made perfect on every quiz, and you have a 21 that is the one you throw out, 21 out of 20. Wow, isn't that tough? I have a student in my 231 class this morning that has 410 out of 410 points.
Good job.
I know. And the girl didn't speak a word of English when she graduated from high school. Not in this country, in another country. So, I don't want to hear any whining from anybody. You hear that?
Is that what you're getting at?
That's what I was getting at. Yeah. So anyway, here we go. Here's the heart. We went over it the other day. With this picture here, you just got to know all that stuff. The heart, the blood is coming back to the heart through the inferior vena cava, superior vena cava, and also through the coronary sinus from the heart itself, dumping into the right atrium, goes through the tricuspid valve into the right ventricle, goes out through the pulmonary valve into the pulmonary arteries. It goes to the lungs, it gets oxygenated, it comes back into the left atrium through the pulmonary veins. From the left atrium, it goes to the left ventricle through the mitral valve, and when it comes out of the left ventricle, it goes through the aortic valve into the aortic arch and to the whole body. There's plenty of pictures in your book that you can see that are much better than that first drawing I had, but nonetheless, the direction of the blood flow is really important. And because we're going to be talking about blood flow and how it flows through the heart and how it goes through the different valves and so forth, but if you don't understand the directions, none of it makes any sense. So please, if you don't have that down yet, be sure you get it down soon. So the point of the matter is, with the heart, we have 2 systems, the pulmonary system and the systemic system. In other words, the blood goes from the heart to the lungs and then comes right back to the heart. That's the pulmonary system. Very low pressure system. It doesn't have to pump the blood very far. There's not a great deal of resistance. It just goes right into the lungs without much trouble, assuming your lungs are inflated with air and so forth. Once it comes back to the heart, it comes back to the left side, and then it gets pumped out through the systemic system, which goes from the top of your head to the bottom of your toes to basically every cell in your body, including sending blood to the heart muscle itself through a system of arteries called the coronary arteries. And when you get coronary arteries blocked up, that's what leads to coronary disease, and that's what leads to myocardial infarctions or coronary artery disease once again. So, once it goes out into the body, it goes up to the head through the carotids and the vertebrals. Remember, it comes down through the rest of the body. It uses up the oxygen in the tissues and brings back the waste products to the right atrium, and it all starts over again. Okay? So, you need to know that there are three basic types of blood vessels. There are arteries. Arteries always carry blood away from the heart. By definition, an artery carries blood away from the heart. Veins bring blood back to the heart. And then capillaries are the little systems of tiny blood vessels that connect arteries and veins. And there's really where either the artery, where the blood picks up its oxygen while it's going through the capillaries of the lung, or where it gives up its oxygen when it goes through the capillaries out in the systemic circulation in the rest of the body. Make sense? Capillaries are where all the action really happens. That's what we call them exchange vessels. And what that means is that they are very tiny and they are very thin-walled, and that allows the exchange of all the good stuff and all the bad stuff to take place. As the blood flows through your finger, the tissues in your finger here, it picks up the waste products, the carbon dioxide and other waste products, carries them back to the heart. It also, as the blood comes out, it drops off the oxygen, the glucose, all the good stuff that all those cells in your finger need. Okay? So that's why we call the capillaries the exchange vessels. The same thing happens with the capillaries in your lungs. They're very thin. The blood flows through them one cell at a time, and that enables it to pick up the oxygen just in a short period of time that it goes through the lungs and drop off carbon dioxide and so forth. So that's it. The anatomy of the heart is pretty straightforward. You kind of know a little bit already. The great veins and the arteries, the things that hold the heart in place, are up here at the top, which is really called the base. Seems backwards, but the base of the heart is kind of the top of the heart. It's surrounded by the pericardial sac, and of course the bottom end is the pointed tip, which is down here, which is the apex. And when the heart beats, it kind of goes, let me use my other hand, it kind of goes like this. It kind of squeezes itself out with each heartbeat. The apex down at the bottom moves around pretty good with each heartbeat. The base, the top, really doesn't, because it's held in place by the aorta, the vena cava, superior vena cava, inferior vena cava, and so forth. Remember the pericardial sac, there's both a parietal and a visceral layer to it. And remember that the heart and the pericardium sits between the two pleural cavities in what we call the mediastinum. Now the pericardium is probably the biggest and most important thing in the mediastinum, but there are other things in the mediastinum too. The mediastinum is defined as everything between the two lungs. Okay? So there's things in there like the trachea, the esophagus, the great vessels, the aorta, the thymus gland, and so forth, that all live in the mediastinum. Okay? You thought you'd heard the end of those body cavities, didn't you? But you haven't. And we have more to come. Anyway, so here you go. Here's kind of the base of the heart up in here, which is where all the big vessels are attached. Here's the diaphragm down here. Here's the apex of the heart. The apex of the heart is sitting in the pericardium. There's the parietal pericardium, which is this sac that sits around the heart. Now, although the pericardium in your cats is like toilet paper, and it just goes away when you get up to the pericardium pretty much. In humans, it's a pretty tough structure, and we sew to it. We also sew it up to the chest wall before heart surgery, so it gives us a nice little cavity there where any blood can collect, and we can suck it out and send it back to the heart-lung machine. The lungs on either side, like I said, here's the mediastinum in between here. I wouldn't really call the thyroid gland in the mediastinum because it's really up out of the neck. I mean, it's not in the chest. It's up higher, but the thymus gland is. It's down about in here. These big blood vessels are in there. The aorta, I mean, not the aorta, but the aorta is one of them. But the trachea and the esophagus are the big tubes that go down there as well. Remember this picture from day one of 231? I think you just got to know it. This is the balloon that is the pericardial sac, and the heart, which is the fist, kind of grew down into it, and that's what gives you the two layers of the pericardial sac. The outer one is called the parietal pericardium. The inner one, which is really right on the surface of the heart and can't really be separated from it, is called the visceral pericardium. Normally, the pericardial sac itself has 3 cc's of fluid or less. I mean, it's just spit in there, so it's slickery, so it can, so the heart can beat and not scrape or scratch anything when it does.
This is the point where cardiac tamponade would be somewhere.
Cardiac tamponade would occur if there was way too much fluid in the pericardial sac. If there's bleeding into the pericardial sac, then the pericardial sac comes under pressure and the veins distend and the pump won't work because the heart has to be able to expand with each heartbeat to fill. But if it's got tamponade and this is all full of high pressure blood out here, it can't. And those people usually kind of collapse and die very quickly unless you can get that relieved very quickly. At the other end of that spectrum, since you asked that question, cardiac tamponade is when this cavity becomes way too full. When the cavity becomes completely empty and has no fluid in it or gets dried up, it's usually caused by a virus or a little infection called pericarditis. Pericarditis and an inflammation of the pericardial sac. Patients with pericarditis have terrible pain in their chest because basically their heart is going rubbing over the pericardium here with each heartbeat, and it tends to be very painful. Patients tend to want to lean over forward to relieve that pressure a little bit. I only diagnosed it once in my life, but my internist friends were impressed that I made that diagnosis for them. Patient that came in with chest pain. You can actually hear what's called a pericardial friction rub. If they have bad pericarditis and it is scraping, when you listen with your stethoscope, you'll hear it going pericardial friction rub. You won't hear it many times. It's not terribly common. Okay, so the pericardium, double lining of the pericardial cavity, has a parietal layer, has a visceral layer, pericardial cavity is really small, contains virtually just a few drops of pericardial fluid in a normal situation. Just know that the pericardial sac is fibrous and it's pretty stout, and you can sew it up with stitches pretty well. I've talked about the order of the blood flow already, so I won't go over it on this picture here, but let's just point out and rename the valves. The valve that connects the right atrium here to the left atrium is called the tricuspid valve, and the reason is because there are 3 separate cusps. Here's 1, here's 2, and the third one is kind of illustrated right there. On the other side of the heart, the AV valve, in other words, the atrioventricular valve, is called the mitral valve, and it is a bicuspid valve. It only has 2. 1, 2. And that's kind of where it gets its name. I'll show you a picture later that for you non-Catholics in the crowd, they'll explain it to you. What? Non-Catholics? Anyway. So here's a slice through the chest. It's really a nice picture. I just have to tell you. Here's the front up here. Here's the sternum and a couple of ribs. Here's a rib. This is the heart. This is the aorta. You notice the aorta comes up, comes over the pulmonary artery here, and then goes back down. It actually connects to that right there.
And that's what creates the arch.
That's the arch of the aorta, yeah. And the trachea, which comes down from above, comes down and splits into the right main stem bronchus and the left main stem bronchus to supply air to the right lung and the left lung. Notice behind everything is this tube right here, which is the esophagus that you swallow your food through, back there and back. So here's the superior vena cava. You don't see the inferior vena cava because it's down below. This is the left atrium, which is receiving the blood back from the lungs. We call those vessels that bring the blood back from the lungs, we call those the pulmonary veins. Veins are bringing it back. So the pulmonary veins are bright red because they've got totally oxygenated blood because it just went to the lungs. Pulmonary artery, which is illustrated here, is pumping blood out to the lungs, and you notice that it's drawn as purple because that blood is deoxygenated because it just came back from the body. So you need to know what is oxygenated and what is deoxygenated. You need to know the names of the valves that it's going to go through and the names of the chambers that it's going to all go through. I can't make it any easier than that. See, I started off here with no labels on it, and then I put labels on it, so you get both in your PowerPoint set. You've got both with or without answers. How's that?
Super helpful. Thank you.
You like that? Is that helpful? Okay, good. Nothing new here. I think I've talked about all of that. Let's look at the outside of the heart, and when we look at the outside of the heart, we see that the upper part on both sides is the atria. The atria, whether the right atrium or the left atrium, they are both very thin-walled. The atria really don't contract much. They don't pump much, but they do a little bit, and so we shouldn't discount it completely. But just know that the atria are very thin-walled as compared to the ventricle, which is very thick-walled. The ventricles are really the ones that pump, okay? The atria have a little outer auricle, which is just a little ear of the atrium that kind of sticks out. You'll see it when we give you your hearts to look at. When you look at the outside of the heart, you'll notice that it has a couple of sulci. Sulci, you remember from the heart, are the little divots, right? So you've got one divot which kind of goes across the heart. We call it the coronary sulcus. And the reason we call it that is because the coronary arteries kind of run in it. Get it? Coronary arteries run in the coronary sulcus, which runs kind of across the heart. It serves as the marker of the division between the atria above and the ventricles below. Okay? Running down the front of the heart, there is another sulcus called the anterior interventricular sulcus. The anterior interventricular sulcus does just what it says it does. It runs between the two ventricles. So the left ventricle's on the left of it, the right ventricle's on the right of it, interventricular sulcus running down the front of the heart. It also contains coronary arteries as well. You'll see that later. So here's what we're talking about here. This is that coronary sulcus that runs kind of across the heart through there and there. You notice here's the right coronary artery is in this. There's circular, circumflex coronary artery that's going around over here. Then there's the sulci. The sulcus, interventricular sulcus is coming right down here underneath that fat. Please notice, one thing you can notice right now is that the coronary arteries, which are going to carry blood to the heart muscle itself, live on the outside of the heart. Coronary arteries that run in through here, that carry blood to your heart muscle itself, run on the outside of the heart. I'll explain to you why later, but just think of it like this. If they ran inside the heart, every time the heart beat, all that muscular pressure would be applied to the outside of those arteries, and blood wouldn't be able to flow through very well while the heart is contracting.
Could it also damage them and break them?
Well, it just doesn't. They just aren't built that way.
Okay.
So yeah, it could damage them. It really bother them. I'm sure it would. There's one last piece of anatomy I think you ought to look at on here, and that is because we're going to talk about this off and on all the way through fetal circulation. Fetal circulation? You mean blood circulates differently in a baby, in a fetus, than it does in a person? Absolutely. This is called the ligamentum arteriosum. It doesn't look like much of anything. It looks like just a scar, and that's what it is. But this used to be in fetal development until the minute the baby was born. This was a wide open shunt that carried blood from the pulmonary artery straight into the aorta. Just file that away. We'll come back to that. This is the back of the heart. And you don't hardly ever look at the back of the heart. The only time you ever see the back of the heart is when the heart has been cut out and handed to you in a pan, which doesn't happen very often, right?
Yeah.
You're going to get one handed to you later today, but that's about the only time you ever see the back of the heart. When you do surgery on the heart, you're looking at the whole front of the heart, but you never really see the back very well. So here's the back side, and the thing I would point out to you, let's go back to this picture. You notice on this picture, you see a lot of the right atrium, and you see a lot of the right ventricle. Those two things on the right side are more or less sort of on the front of the heart, when the heart's laying in the chest. But if you look at the back of the heart, finally you get to see the left atrium. You didn't get to see it really at all. Here's all you got to see is that little tiny tit of the left atrium over there. This is the left ventricle. You see a little bit of it too, but the left ventricle also occupies most of the back of the heart. So here you have left ventricle occupying that much. Here is the right ventricle over here. Right atrium you can still see from the back, but left atrium you can finally really see well. And notice that there are two major right pulmonary veins bringing blood back from the lungs, going into the left atrium. 1, 2, 3, 4. You don't get to see any of those from the front. Okay? Also notice when you look from the back, you can see the inferior vena cava, which is bringing all the blood from the lower part of the body. And you can see nicely the superior vena cava, which is bringing all the blood down from the top end as well, although you can see that from the front as well. Here's the arch of the aorta coming over. Leave it at that. The things that you do see on the back here that you should be aware of is this is the blood vessels that are collecting the blood that went through the heart muscle itself, called the coronary blood vessels. And the blood, when it drains out of the heart muscle itself, it collects up here, collects in this big vein that runs kind of across the back of the heart. This part of it over here is called the coronary sinus. And this little sinus, about there where that dot is, has a connection into the right atrium, right there behind it, that dark purple area, part of the right atrium. And that's where the blood from the heart itself returns to get back into the circulation after percolating through the heart muscle itself. Coronary sulcus, we talked about it, it goes around the back as well. Interventricular sulcus also goes down and back, but once again, you hardly ever see it. This is the sulcus between the left ventricle and the right ventricle. Okay? Pretty cool, huh? Usually when you examine somebody's heart, you always search for what's called the PMI. The PMI means the point of maximal impulse. And if you put your hand on your chest now or later tonight and feel for your heart, you should feel one particular spot where you can feel it better than others. In fact, usually if you kind of lean over a little bit, your heart will actually come up and kind of tap your finger. That's supposed to be in the fourth intercostal space at the mid-clavicular line. So here's the clavicle. The mid-clavicle would be right there. Come straight down from that. That's the mid-clavicular line. So you'll see it written in the chart a lot. Fourth ICS, fourth intercostal space, MCL, mid-clavicular line. That is a normal position for the heart to be. Now, if the heart is way out lateral and way down farther in the sixth or seventh intercostal space, and it's out lateral to that, something's wrong. And it usually means the heart is really big and it's failing. Most big hearts are caused by heart failure. So if you see it out here and you feel it out there, that's not a good sign.
And it's caused what was the original thing you called it?
PMI. What is that?
PMI. The reason you feel the PMI is because of the apex of the heart.
Yeah, it's the apex of the heart is what you're feeling.
What does
And if it
PMI
moves out here, it's because the heart is big.
What does it stand for again? PMI.
Point of maximum impulse. Okay, let's talk about the wall of the heart itself. The wall of the heart is basically just muscle. It's just basically heart muscle. We call the outer layer of the heart from the outside, we call it the epicardium. Really what it is that visceral pericardium. Remember, the fist and the heart. That's the outer layer of the visceral pericardium, and all it does is cover the heart. The myocardium, the main muscle of the heart, is the whole thickness of the heart itself. It's the muscular wall, it's a bunch of layers of cardiac muscle, and basically it goes up in the atrium and kind of wraps around the great vessels that are either coming or leaving the heart. The endocardium is the inner surface. It's simple squamous epithelium. We've talked about that since back in 231. The inner lining of the heart, the inner lining of all of the blood vessels, arteries, veins, pulmonary arteries, systemic arteries, everything is simple squamous epithelium. Same as the lining of all the capillaries, so all that exchange business can go on as the blood's going through the capillaries. Endocardium. I'll tell you, I'm going to give a moment of shout out here for the endocardium. The endocardium is probably, in my mind, the most amazing surface substance in the world. And that is the entire reason that we have not been able to develop artificial hearts. It's simply because we can't create a surface that is even 1/10 as good as the endocardium. Think about what it does. First of all, it's alive. Second of all, it's tiny thin. It's simple squamous epithelium. But the main thing is it does not allow blood to clot on it. Every time we humans have tried to put anything inside of the heart and put an artificial material in there, whether that's a heart valve, whether that's attempts that were carried out back in the 60s and 70s of implanting artificial hearts, the problem has always been that clots form on the inside of any of these things where the blood flow is flowing by. And then when those blood clots form, then they break off and go to the brain and cause strokes, go to the kidneys and cause kidney failure, go to the legs and cause amputations. Clotting and the understanding of clotting is so critical in this business. And the endocardium, I just think, is really cool. So keep that in mind. If one of you wants to get a Nobel Prize or a dozen Nobel Prizes, invent a surface that does what endocardium does. Because if we could line pumps with that material, then we could easily put heart pumps in, and artificial hearts in, and all kinds of stuff that would be revolutionary, would be wonderful. So here's a picture of the muscle. It's basically, this is the pericardial cavity out here between these two. Here's the parietal pericardium, which is kind of tough, as I mentioned. It has a dense fibrous layer. Here's the heart itself. This is the epicardium out here. This is the muscle, the myocardium here in the middle, and on the inside is that endocardium that I was talking about. That's so impressive. Please notice that the way that the heart contracts is illustrated right there. Is kind of a squeezing and wrapping to kind of wring it out with each heartbeat. Remember intercalated discs.
Yes.
Remember those guys? And remember that what do? They join two heart muscle cells together in 3 different ways. Mechanically, chemically, and electrically. That's right. They join the muscle cells together at the intercalated disc. That brings all of those muscle cells that are connected there into one. They act as one. And when they contract, they all contract. When the sparks go through them, the action potentials, they all contract and all that stuff. So intercalated discs are cool. Remember them. Here's a nice, beautiful, God, what a beautiful picture of intercalated discs. My goodness. Remember, cardiac cells, cardiac muscle only has 1 nucleus per cell, although somebody found in a book the other day that they can have 2. I haven't seen them. But anyway, remember they sort of sit in the middle of the cell. They don't hang on the edge. Remember the skeletal muscle nuclei always hang right on the outside. And also notice that cardiac muscles cells divide and branch. And that is something, of course, that skeletal muscle never did. It was always just straight as an arrow with thousands of nuclei. So, characteristics of cardiac muscle cells: small size, single central nucleus. I think we're going to still kind of stick with there just being 1 nucleus per cell. And remember, there are all of these branching interconnections, so the muscle cells themselves branch, and they have the intercalated discs. Okay, a little bit more of the internal anatomy of the heart. First of all, know that there is an interatrial septum. The interatrial septum divides the 2 atrium. So it forms the wall between the right atrium and the left atrium. There's an interventricular septum, which, guess what? It separates the 2 ventricles. So the interventricular septum runs down the middle of the heart and separates the right ventricle from the left ventricle. The AV valves, there's 2 of them. One of them connects the right atrium to the right ventricle, and we call that the tricuspid valve. And there's another one that connects the left atrium to the left ventricle, and we call that one the mitral valve.
Also known as the bicuspid valve.
Also known as the bicuspid valve and the tricuspid valve. Got it. The way heart valves work, I don't know if you ever really thought about what they do, but what they do is they allow blood to flow in only one direction. So if this was a pipe here coming up out of one heart chamber and it was going into the next heart chamber, and my hands are a heart valve, okay? So they kind of come together, and then when this lower chamber pumps to push the blood up, the pressure changes, and the valves simply open. They rotate open like that, and now it's wide open. The blood flows through until it's empty, then the pressure changes back, and those two cusps snap shut. That's a heart sound, by the way. But that's the way heart valves work. They open and close. And we would like them to open widely so the blood can flow through easily. We would like them to close completely so that no blood goes back through. Okay? We'll talk about those problems.
How does that relate to the ejection fraction?
Ejection fraction is what percentage of the blood that was in the ventricle actually ejects with each heartbeat. We will talk specifically about that a little later. So remember that the right atrium has three main sources of its blood that's bringing blood back to the heart, to the right atrium. They are the superior vena cava from the top half of the body, the inferior vena cava from the lower half of the body, and the coronary sinus, which is the those big cardiac veins that you saw running across the back of the heart, dumping blood right into the right atrium to go back to the lungs and get reoxygenated and come around again. The right atrium, between the right atrium and the left atrium, before birth, in other words, in fetal life, there is an opening between the right side of the heart and the left side of the heart. And so the blood is basically bypasses. Instead of going the normal way, which would be down through the tricuspid valve and on down into the right ventricle, it takes a shortcut and just goes right across through the foramen ovale, the oval foramen that goes through the atrial septum, and it connects it, and it allows blood to flow in that direction. That thing snaps shut and seals off at birth, and then it kind of scars, and as the baby gets bigger, it's nothing more than a little hole there, a little dimple there, which is called the fossa ovalis, which is basically just the leftover of the foramen ovale. Fossa ovalis.
It's just like the closure.
It's just where it closed, yes. The right atrium, when you look inside of the right atrium, as you will later, you look inside and you'll see that there's a bunch of ridges of muscle that are inside the atrium. They're called the pectinate muscle. They're very prominent. You can't miss them. They're mostly on the anterior atrial wall, and you should be able to see those and identify those. Man, that's a complicated picture. Why'd that come up? Let's just keep walking through here. Maybe I'll come back to that. So that was the right atrium we were talking about. Now let's move to the right ventricle. The right ventricle is this chamber right in here. And this chamber has several kind of cool things about it. One of the things that it has these cusps on the valve. Remember, there's three of them. And they are held in place by these things called the chordae tendineae. So from the edge of the valve here, there's these tough fibers that connect down to this thing called the papillary muscle, which then becomes part of the muscle of the wall of the heart there. And all three of them have that. The idea of these chordae tendineae is they are restrictors on this valve, so that when this part of the heart here clomps down and wants to push blood out this way, you need to close this valve, right? So when it does, it pushes these three leaflets closed, 1, 2, 3, and these chordae tendineae keep that valve from actually being pushed all the way up into the atrium and then leaking, okay? So they're basically supports for the edges of this valve to keep it from flopping back up into the atrium and then becoming insufficient. In other words, leaking backwards. That's the chordae tendineae. Now, why are they attached to papillary muscles? You might say, well, why do they need to be attached to a muscle? Well, the reason is because as this part of the heart contracts, if you had it just attached to a solid thing that didn't get shorter, it would be the same deal. As the heart closed in, this would get closer, which would allow this to slide up and allow this to flop back. Because it is a papillary muscle, As the heart gets smaller, this gets shorter and holds it there. Does that make sense? It's really kind of a cool deal, the way that works. Notice that there are papillary muscles on this side, and there are papillary muscles over here attached to the leaflets of the mitral valve as well. We'll get to them. Okay, so you will be able to see these papillary muscles on your hearts. They'll be attached to these little chordae tendineae, and then the chordae tendineae will be attached to the cusps of the AV valves. Okay. Also notice that there is these little trabeculae. They're called trabeculae carni. What's that Mexican dish? Carne something? Carne asada. Yeah. Same thing. They're eating hearts. No. Just means meat or muscle. But yeah, so these things down in here are called the trabeculae carni. You can see them in both of the ventricles. The inner surface of the heart is not smooth. It's got all these muscle fibers that kind of stick out like that. The other one that you do need to identify and see is this big one down here that goes across the bottom of the right ventricle, and it is called the moderator band. I will just tell you that the reason for the moderator band is that the moderator band has some nerve connections across in there that help scatter out the pacemaker signals to the heart, keep it all beating together. They are in that band, but it's very obvious when you look inside the heart, and you can see that. The ventricle on this side, this right ventricle, then kind of points up, and this is called the pulmonary opening. Pulmonary opening, and the pulmonary valve is a triple valve, 1, 2, 3, called a semilunar valve. They're called semilunar valves because they look like little moons. They open and close. I've got a video that will show you this a lot better than I can describe it. But this is a tri-valve, trilunar valve, tri-semilunar valve, 1, 2, 3. The aortic valve coming out and going out the aorta is also a semilunar valve. Semilunar valves don't have any of these papillary muscles or chordae tendineae to them. Okay, so in this squeezes, it pushes the blood out. The pulmonary artery, also called the pulmonary trunk. I don't know why. It's always been called that. That's the pulmonary trunk, and it splits into the right pulmonary artery over here and the left pulmonary artery over here. Remember that the pulmonary artery, even though it's a totally deoxygenated blood, very deep purple blood, it's an artery because it's leaving the heart. To go to the lungs, that's right. Okay. I think I've talked about this. Here's a look inside of your heart, or a heart. These are the papillary muscles down here. They are attached to chordae tendineae that go to the edges of the valve up there. Now, I will have to tell you that this looks like a really nice heart, but that person is dead. And how do you know they're dead? Because what is filling their heart? Either air or water. Yeah, air or water. And that probably is not very compatible with life, as you probably know. Okay. Trabeculae carni, those muscular ridges I've already mentioned. The biggest one is the one down at the bottom of the right ventricle, which is the moderator band. It contains a part of the conducting system of the heart. Leave it at that. Pulmonary circuit. That's another name I didn't mention to you. The conus arteriosus is kind of the cone of the right ventricle as it goes out into the pulmonary artery. The conus arteriosus. Let's just go back here and show you that. This part right in here, coming out there, is called the conus arteriosus, going into the pulmonary artery through the pulmonary valve.
It's just the space.
What?
I said it's just the space? Is the name just for that space?
Your question, is it named for that space?
It's just, conus arterius is just the name for
Just
that
means
specific space.
The distal part of the pulmonary artery outflow tract before it gets out of the pulmonary artery. Then it turns into the pulmonary trunk, and then it splits into the right and left pulmonary arteries. The pulmonary valve has 3 semilunar cusps. Okay, so now let's go to the other side of the heart. Now the blood has been to the lungs, and now it's coming back. It comes back into the left atrium. It goes into 2 rather large left pulmonary veins and 2 rather large right pulmonary veins, which I showed you from the back of the heart. You can see those 4 big vessels coming back into the heart. They're coming into the left atrium. Now remember, even though they're called veins, they're carrying bright red blood because it's just coming back from the lungs. Okay? But remember the definition: artery leaving the heart, vein returning to the heart. Pulmonary veins dump the blood into the left atrium, and from the blood, once it's in the left atrium, it goes through into the left ventricle through the left AV valve, which is also called the bicuspid valve, and it's also called the mitral valve. I can tell you, we always call it the mitral valve, just to make it simple and short, and then there was no question of right or left or anything like that. It was just the mitral valve. And there's a whole lot of diseases that are related to the mitral valve: mitral stenosis, mitral insufficiency, lots of problems that are related to that. This is why it's called the mitral valve, this spunky little miter. This is called a miter that the uppity-ups in the Catholic Church wear. And you notice that it's got 2 cusps, front and back, up here at the top. And that's the word in Latin, I guess, for miter. And somebody, when they first were looking at mitral valves, they looked at that and they said, oh, that looks like the Pope's hat, you know, so it became the mitral valve. That's important. The left ventricle. The left ventricle is really where most all of the action is in the heart. It's the one that has to be strong and powerful. It's the one that's going to give you all, that's going to kill half of you in this room, is problems with your left ventricle. It's half of everyone, just so you know. Most of us die of heart disease. And when we die of heart disease, we're almost always dying of problems with our left ventricle. Because the left ventricle is so much bigger and so much thicker, it needs so much more oxygen, and it sometimes doesn't get it, and when it doesn't, that's a heart attack. And basically, almost all heart attacks involve the left ventricle and the left ventricle only. Okay? So, the left ventricle, it holds the same amount of blood as the right ventricle, because as I told you the other day, the right side of the heart has to pump exactly the same number of cc's of blood with each heartbeat as the left side. But remember that the left ventricle is much bigger and much thicker. At least from the outside it's bigger. The muscle is much more thicker. It's much more powerful. But it still carries the same amount of blood. It does not have a moderator band on the left side like it did on the right. And remember that when blood pumps out of the left ventricle, it goes through the aortic valve and into the ascending aorta, turns around, sends blood up to the brain through the big arteries on the top of the arch, and then comes back down and goes to the rest of the body through the descending aorta. So there's an ascending aorta, which is really short. There's the arch of the aorta, which is also pretty short. And then there's the descending aorta, which is coming back down. Now, I think this is really a neat picture. I'm sure y'all aren't very excited, but just want to tell you that this addresses what I've been saying. First of all, please notice that the wall of the left ventricle is about twice or 3 times as thick as the wall of the right ventricle. Because remember, while the right ventricle has to pump, the same amount of blood, it doesn't have to pump it with very much pressure. So pressure in the right side of the heart never gets higher than about 30. And it pumps it out into the pulmonary arteries. And the pressure in the pulmonary arteries is about 30/3, systolic and diastolic. And also, so the muscle is thinner, but the volume is the same. Notice that the left ventricle, because it's the one that has to generate all the power, is pretty much round. And the right ventricle, which is sort of along for the ride in some ways, is just kind of moon-shaped and hangs here around the outside sort of the ventricle, of the left ventricle. Fills with blood, empties with each heartbeat. Fills, empties, fills, empties. But the change in volume of the right ventricle and the left ventricle are exactly the same. Even though the shape is different, even though the musculature in the wall is different, the amount of blood it pumps is the same on both sides. Okay, heart valves, let's talk about them a little more specifically. There's two pairs of them. There's 4 heart valves in your heart. They're all one-way valves. They all open and they close based on only one thing, and that is the pressure on either side of them. In other words, if the pressure is high below the valve, the pressure opens the valve up. Then if the pressure gets higher on the top, they come back down and close. It's strictly, they are not self-powered in any way. There is no other control of them. All they do is sort of flop in the breeze. But the breeze is pretty organized so that they open and snap close, open, snap close. Love dub.
It's not the valves closing.
It's the valves closing. We're going to talk about heart sounds shortly. We're getting close. There are two pairs of valves really. 2 of them are called AV valves. That you can call them the right AV valve and the left AV valve, but generally we call the right AV valve the tricuspid valve, and we call the left AV valve the mitral valve. Okay? Then when we, let's keep going here. The thing about these AV valves is that they are between the atria and the ventricles. It's a blood pressure drop that closes the valves during ventricular contraction, and these papillary muscles and the tense chordae tendineae, which prevent the valves from flopping back up into the atria. The other 2 heart valves are called semilunar valves because they look like little moons. Lunar, get it? The pulmonary valve, which is going out the pulmonary artery, and the aortic valve, which is going out the aortic valve, is going out into the aorta. They are both semilunar valves, and they simply open and snap shut, open and close. We have a good video. I'll show them to you. These don't have the chordae tendineae to hold them from flopping back. They just don't flop back because of the way they are built. And I think this is a really good line right here. It says the 3 cusps support like a tripod. You know how if you have a tripod for your camera and you snap it open and you set it down, it's very powerful. It'll hold a lot of weight, and it'll open and close and open and close to that same amount. And it's the support that the cusps create is quite great, and it makes them pretty powerful valves. The other thing that's really important to know is the story of the aortic sinuses. Aortic sinuses. This does not refer to breathing or talking or anything like that. But if we look at the aorta, here's the aorta coming out of the heart, and there are these 3 valves. I'm going to just draw it as closed like that. So here's the aortic valve, So this down here is the LV, left ventricle, right? LV squeezes, causes these three cusps to open. Blood flows up into the aorta, causes the aorta to expand, causes all the arteries in your body to expand. That's what creates your pulse. Okay? You're actually feeling that surge of blood with each heartbeat coming out here. Well, the thing that's kind of odd about the aorta is that in the wall of the aorta, just outside of the aortic valve, and I'm talking that far outside of the aortic valve, there's two little holes right here. One on one side and one on the other. And they connect to the coronary arteries. This is where, these are the coronary arteries. The right and left coronary arteries come out of the aortic sinus. So this area right in here is called the aortic sinus. And basically it's just right above the valve. So as the blood comes out and then pumps back, it snaps the valve shut. And guess what? The blood at that time flows into the coronary arteries. Now, I want you to know that that's really important, because what that means is that blood is flowing into the coronary arteries during diastole, which is really the rest period of the heart. Normally, most blood flows during systole, when the heart is contracting, but blood in the coronary arteries is just the opposite. It goes up, comes back, and during diastole, when the heart itself is resting, is when this blood is coming into here. Now, why would you design it that way? Huh? Why would you design it that way? Did you say talk to God?
Yeah.
Okay, talk to God. Tell me what he says.
Or would it just be the pressure?
Yeah.
Too much pressure going through around the heart.
Well, yeah, you've sort of got it.
But
The
wouldn't
problem is that you want this blood to flow down here along the outside of the heart, and then you want it to flow into that thick muscle, right, to get into the heart itself. And you can't really get it in there when the heart is squeezing. You need it to flow in when the heart is relaxing. So that's why it works that way. We will come back to this concept later on. But did that make any sense to you, Gina? You're looking at me like I'm some kind of weird guy, which I am. Okay, so the aortic sinuses are right at the base of the ascending aorta. They are just above the cusps of the valves here, and they form the origin of the right and left coronary arteries. If you look down from above, it sort of looks like this. This is the four valves, even though on our diagrams they don't look like they're this way, but really the four valves are all in kind of one plane here. Here's the two AV valves going down. This is the right one, the tricuspid. This is the left one, the mitral. And then coming back up, this is the aortic valve, and this is the pulmonary valve. And now remember that right above this, just another millimeter or two north of here, is where the coronary arteries are going to come out of the aortic sinus there, just above the aortic valve. Obviously, when the ventricles are relaxed, the blood is flowing down into the ventricles to fill, so these two valves are open. Then when the heart squeezes, it forces these two valves to close, it forces these two valves to open, and it looks like this. Once again, it's a lot better in animation, which I'll show you later. This is a terrible picture. I think this picture here is worthwhile. This is the shape of a semilunar valve. You notice they have edges that meet up just perfect like this. There's a little cusp in there, and when they come back down, they meet up, and this whole thing becomes solid. This is dark not because it's open, just because there's no light shining on it. When they open, they flip up this way and get out of the way. I don't like this picture. That's why I put that silly note on the bottom of it. But I think if you just look at this one little bit of it, then it's somewhat helpful. There is a thing called the cardiac skeleton, which is kind of a tough band around the 4 heart valves. It kind of keeps that part of the heart from getting bigger. Obviously, if these bands around the aortic valve, or around this valve, for example, were to get bigger, and if this was to open up, then your valves would not meet up, and you'd get a lot of blood leaking back with each heartbeat. So it's very important that the valves all are stabilized. The other thing it does is it sort of insulates the ventricles from the atrium. We'll talk about the electrical blood flow, and the electrical flow through the heart. We're going to talk about EKGs. We're going to talk about how the heart fires off and so forth before this is all over. Okay, so the blood supply to the heart itself, the heart muscle itself, is called the coronary circulation. It involves the coronary arteries, which I just drew for you over here. They both leave from the base of the aorta, just right above the aortic valve in the aortic sinus, and that takes blood to the muscle tissue of the heart. It percolates the blood through the heart, giving the heart muscle itself oxygen, and then it collects back through those cardiac veins, and the veins collect it on the backside of the heart in that thing called the coronary sinus, and then empties into the right atrium to go back into the heart. Coronary arteries, there are 2 of them, left and a right. You've heard of people having quadruple bypasses or triple bypasses. That's because they've had a bypass to their right coronary artery, to their left coronary artery, to their circumflex coronary artery, and maybe even to their anterior descending coronary artery. There's a bunch of branches, but there's 2 major branches, the left and the right. You guys have any idea what having heart surgery is all about? You understand what that means when you have a bypass to your heart? Well, it is rerouting it. Let me draw that over in lab. These pins I have in here are so awful. Well, I can show you on this picture here. Here's the right coronary artery coming out of this aorta right there, just after it came out through the valve, remember? That's the right coronary artery. Here's the left coronary artery. The one thing about coronary artery disease, which is a buildup of cholesterol and plaque, which leads to narrowings of these arteries. And you'll hear people say, well, mine were 90% or 95% or 99% narrowed off. The one thing we've got going for us is that they usually do most of their narrowing right here in the first inch of the coronary artery, here and here. Sometimes down here into the anterior, this is called anterior descending artery. They call it the anterior interventricular. This one's called the circumflex, which goes around and back. Because they usually narrow right here, if we can bypass around that, we can get more blood down to here, for example, then we can really help the patient out. So bypass surgery, which is by far and away the most common open heart operation done in America, you take a piece of their saphenous vein out of their leg usually, or there's other things they're using these days, but you hook it in here, you sew it in, this little pipe, and then you string it out here and you sew it in down here, past the narrow spot. And then sometimes if you can do one to here, one to there, one to there, one go all the way around and back and hook it into the circumflex. I've heard of, people have had five bypasses. That's a lot of time. That's a lot of little tiny microscopic suturing. Yeah.
Does the bypass have to occur in the aortic sinus area?
In the what?
Does it have to occur in the aortic sinus?
Does the bypass? No.
No, but you have to.
You have to hook the things in here.
Yeah.
Well, you usually do because it's closer. Actually, these days, sometimes we use the lima, the interior mammary artery, which is an artery that runs down the underside of your sternum, take that artery and hook that in.
Oh, okay.
But most of the time it's done off the aorta here. More of the coronary arteries, here they are. Two of them come back here. When the blood it's gone through the heart, then it goes into the coronary sinuses here, the middle cardiac vein, posterior cardiac vein, great cardiac vein, and the end of the coronary sinus. I don't care if you know all the names of those. You probably need to know the names of the arteries because that is such a common thing. I would just say that we usually call this one the LAD. You'll hear that term around the hospital a lot. He had a bypass to his LAD, his left anterior descending, his circumflex, or to his right coronary arteries over here. Okay. Right coronary artery is important. It supplies blood to the right atrium, but it also supplies portions of both ventricles. But this is kind of the important part, is it supplies blood to the sinoatrial node and the AV node. The sinoatrial node and the AV node are electrical nodes. The SA node is basically the pacemaker of your heart. The normal pacemaker of your heart is the SA node. So if it's not getting enough blood, then your heart doesn't beat properly. And, patients will come in with a heart rate of 30, little guy, poor old guy. Every time he stands up, he gets really dizzy, and he gets up again, he gets really dizzy again. You check his pulse, and his heart rate is 30 or 40. And so his heart is only beating 40 times a minute, and that's just not enough for him to be able to stand up. And that's because he has, we usually call it sick sinus syndrome. His sinoatrial node is not getting enough blood. He's going to need a pacemaker to speed his heart rate up, and he'll do just fine. The marginal arteries supply the surface of the right ventricle, posterior interventricular artery. I showed that to you. Those are all supplied by the right coronary artery. Here's the left coronary artery. It's the more important one because it supplies nothing but the left ventricle. And I said from the beginning that the left ventricle is the thing that was going to kill half of you, including me. And that's this little coronary artery right here. Here's a pearl that you need to know. This is called the left main. The left main coronary artery is called the widowmaker. And the reason it's called that is because it has such a high mortality. Anybody that has narrowing of their left main along here has a very, very high chance of death soon. So in general, when the arteriographies are squirting dye into the arteries, and they find a patient that has a severe narrowing of their left main coronary artery, they don't even stop. They go right out of the x-ray department, go right into the operating room, and get them fixed right away, because those patients have a tremendous risk of dying in the next 24 hours because the left main is just so critical. And just having squirted the dye in there can change things enough that they go on and clot. Obviously, if you clot off your left main, you're dead. So we call that little piece of artery there the widowmaker, left main. Obviously, it splits right away into the LAD, the left anterior descending, and the circumflex, which goes around to the back. Both very important in keeping your heart muscle itself alive. The left coronary supplies the left atrium and the left ventricle and the interventricular septum. The interventricular septum is really important because the interventricular septum contains the Purkinje fibers and the little electrical nerves that go down through the interventricular septum to carry the shock with each heartbeat that comes from the SA node. It comes down through the interventricular septum. And so if that's not working, then you get things like bundle branch block and the different parts of the conduction system don't work right. We will come back to that, and those words will make more sense to you later. So I said the two main branches are the circumflex and the anterior interventricular, or the LAD. They have anastomoses that connect these two circulations, which stabilize the blood supply. What does that mean? Well, that means that there's one set of blood that's coming down this way and going out into all of these tissues. There's another set of blood that's going around here and coming out into all of these tissues. And even if one of them is blocked off to some degree, you'd like to think there would still be enough blood working through the anastomoses, where the arteries kind of come together, to keep a piece of heart muscle out here alive. Our heart really depends on all of these different anastomoses, where the blood's coming from several different directions to supply the same area. Yeah.
Is there a cutoff point for a symptomatic heart attack, or for you to have an infarction that you feel can happen inside the capillaries of the heart, or does it have to be in like Venn diagram parts of the artery C?
Yeah, the heart attack is usually not caused necessarily by one of these arteries being completely clogged off. Usually it's caused by a little clot. The clot may have formed up here, but then it flips off and goes down here to one of these branches, and that leads to a small area of your heart dying. Since we're talking heart attacks here a little bit, let me just say that you've always heard the story about how, oh, Mr. Jones, he had a massive heart attack and he died, right? That's the standard line. Oh yeah, Mrs. Jones, she had a massive heart attack. Well, the fact of the matter is most people don't have massive heart attacks. What they have is little heart attacks. They'll have a little heart attack in, say, this area right here, but that leads to a piece of cardiac muscle in there that is irritated, and it starts sending out shock waves. It starts sending out PVCs, premature ventricular contractions, abnormal beats. Next thing you know, that little pacemaker from that piece of dead muscle, those little shocks take over. And instead of doing the nice like this, it takes over, and now the heart starts doing like this. And that's called fibrillating. And when the heart is fibrillating, it's contracting, but it's not pumping any blood at all. So when the blood isn't pumping any blood, it's lights out. Unless you can shock them and get control of that electrical impulse, or give them drugs or whatever, they're going to be gone. So most heart attacks, I just think that's really important that you keep in your mind. It's not usually that a big, huge piece of their heart muscle dies. It's usually that a small piece dies, and then that one piece starts an electrical event that is the problem. That's why it's so important to have these AEDs that you can just put on people, and it reads what their rhythm is and decides whether or not they need to be shocked, because the idea of shocking them is not to start the heart back again, it's to stop the heart, stop all of those funny beats, and then hopefully the normal pacemaker will take over again, and the patient will be in a regular rhythm.
How does the pacemaker work?
Let's hold that if we can. Yeah, pacemaker just is an electrical shock maker. It just makes an electrical shock that spreads around the heart and fires it off.
But you would still, if you have one, you still have a heart attack,
It's not going to stop you from having a heart attack. No,
but it's not going to shock it back.
no. That would be a defibrillator. People do have defibrillators inserted that will shock their whole heart again if they go into defib. Okay. We talked about the veins taking the blood back to the back of the heart. I think we've said enough about that stuff. That's the back side. This is an arteriogram. This is actually a nuclear medicine arteriogram. But you squirt dye in up here at the coronary sinus. It goes out through the two coronary arteries here, flows out down through all the coronary. Here's the LAD coming here. Here's the right coronary going there. That one's pretty normal looking. This one, you notice, has just almost areas like right there. It doesn't look like there's hardly any getting through it. tiny complete narrowings here and here. I think I have some other pictures of black and white arteriograms that I'll show you later that'll make a lot more sense, maybe. Okay. All right, so we are at the slide that says heartbeat. The next thing we're going to go through very patiently and slowly so that you understand it is everything that's involved in one beat of the heart. What does it take to make that all work, and what does it make to have that, have it all do it in the right order and in the right timing and so forth to make your heart beat normally. So that's where we are. Let's go to loud.